Hi, I'm Paul Atkinson, and welcome to this brief introductory talk to point-of-care ultrasound for the undergraduate curriculum at Dalhousie University Faculty of Medicine. So I wonder if any of you recognize this quote and this famous physician. Its use by non-specialists could be dangerous and should not be encouraged. Well, this quote was by the late great Austin Flint in 1856, and in fact he was talking about the stethoscope, which of course we all now use standardly on a daily basis. But how about if, rather than just listening for the echoes of sounds created by the heart, the lungs, we could actually generate our own echoes, that is ultrasound, and actually see the anatomy and physiology of the heart, lungs, and other organs. Could this be revolutionary in how we assess patients and make clinical decisions? Well, it actually has become so and is now considered standard of care in many specialties. Here we have an image of a beating heart, the ability to assess the form of the heart, that's the shape, size, the function of the heart, how well it is contracting, and also looking for fluid, key components of basic cardiac ultrasound or echocardiography. Being able to look at major vessels such as the aorta and IVC can help clinical assessment at the bedside in critically ill patients. Assessment of intrauterine pregnancies, again in patients with abdominal pain or bleeding, can be very reassuring and also life-saving. Ultrasound, of course, allows us to make measurements, to screen, and to perform surveillance of patients as well. So in the Peer 1 program, we will introduce you to the concepts of ultrasound. We will also introduce you to ultrasound physics and instrumentation, that is the use of ultrasound machines. There will be teaching on the core undergraduate applications, which will incorporate some practical sessions and some simulation. We then encourage you all to gain clinical exposure and maintain your practice during your clinical rotations. So a little bit about the background of how we've ended up using ultrasound in medicine. Well, traditional users of ultrasound technology have included radiologists, obstetricians, and cardiologists. In clinical medicine, this is now expanded, and early adopters of point-of-care ultrasound or bedside ultrasound include specialists in emergency medicine, intensive care, vascular surgery. One of the key moments in the development of ultrasound as a clinical tool were the recommendations from many specialist organizations for ultrasound guidance for the placement of central lines. In family medicine, some European countries have been using ultrasound for many years. And in fact, again, specialist organizations have outlined their recommendations for the use of ultrasound in family medicine or general practice quite some time ago. But however, what really changed the uptake was the availability of low-cost portable ultrasound machines. As you can see, carting around this type of enormous ultrasound machine would not be practical in most clinical settings. Even the traditional radiology machine can be quite cumbersome, can take quite a while to boot up, and can be intimidating for the clinician. The development of portable ultrasound machines that can be almost carried around in your pocket and which give acceptable quality images has revolutionized the use of ultrasound at the bedside. So again, just to differentiate, diagnostic ultrasound or that is a full study carried out by a radiologist or sonographer, an echocardiologist, or again sonographer, where a full, comprehensive, thorough interrogation of the organ in question is carried out, independent to the clinical assessment. Point-of-care ultrasound does not aim to replace this departmental or diagnostic ultrasound approach. Rather, point-of-care ultrasound is a bedside tool to be integrated into the clinical examination that should provide extra information to the clinician during the initial and follow-up assessments. Examples are emergency ultrasound, procedural ultrasound, critical care ultrasound, to name a few. Why do we need such a tool? Well, many studies have shown that clinical examination is unreliable. Certain diagnoses are very difficult to make with your hand, stethoscope, and simple bedside tests. So we know we're not very good. POCUS is the fifth component to the clinical examination in many specialties and does improve our clinical yield. The concept that we are trying to establish is not necessarily that of noticing every detail, rather to note the major abnormality that one is looking for. For example, in this picture, to be distracted by people on the beach or the beer, and to become interested in that misses the point that the airplane is the obvious abnormality and should not be there. So the concept of looking for the abnormality in point-of-care ultrasound is one that must be emphasized. As such, that is in fact a limitation but also a benefit of this approach. It is a goal-directed, focused examination to answer a specific question, such as, does this unwell patient have an aortic abdominal aneurysm? The answer may be yes, no, or I'm not sure, in which case further investigation may be required at that time. In terms of how you obtain the scan, I think it is helpful to consider your ultrasound probe in a light similar to that of a sword. That is that one needs to slice through the organ we want to visualize. That will create two-dimensional images, such as a sliced pepper, which will vary depending on which plane the organ is sliced. Do not expect to see a three-dimensional reconstruction. Rather, multiple two-dimensional slices must be reconstructed in one's mind to achieve an assessment of the whole organ. The key to success with ultrasound, as with many other clinical activities, is background knowledge, in this case anatomical knowledge. One also needs to be prepared to know your machine, to practice, to audit your practice, and to seek local support and training. So now to discuss some of the physics behind ultrasound. Essentially, ultrasound waves are high frequency waves that are inaudible to the human ear, that are generated by the transducer due to the vibration of crystals in the ultrasound probe. Ultrasound is then introduced into the object, in this case a body. Four things can happen to it, essentially: attenuation, refraction, scatter, and reflection. And the ultrasound probe listens for any returning echoes in order to generate the image. Attenuation is a simple concept. Mechanical waves lose energy as they travel through substances, and therefore, especially with high frequencies which have low wavelengths, the penetration of a substance is diminished because it loses energy as it travels through the substance. Refraction is essentially a change in the direction of the wave as it hits an interface, similar to how a straw is seen in a glass of water or how a rainbow is created. Scatter is whenever sound waves are dispersed and not reflected in any meaningful fashion. This can be seen whenever ultrasound waves hit an air interface. Finally, reflection, and this is how image generation is achieved. Sound waves are bounced back from an interface or from a hard surface, and these waves re-stimulate the crystals in the ultrasound probe, which generates brightness or whiteness echoes on the screen. To summarize all of that in one slide, essentially, the brighter parts of a screen are due to reflection, and darker parts have no echoes. Essentially, substances that are highly reflective or high impedance, such as bones or stones, will therefore appear white. Fluid, which does not reflect sound waves, will appear black, and organs such as the liver, spleen, and kidney will have a grey appearance. Again, just to remind you that air or gas scatters sound waves, and therefore you have a snowstorm appearance. It's uninterpretable, and one must maximize attempts to reduce or remove air from the field of vision. Inside the body, loops of bowel, lung, etc. are filled with air and should be avoided. Outside the body, air between the probe and the patient is a problem, and therefore we use gel to improve the transmission of sound waves from the probe to the skin. The idea of an acoustic window is similar to a window in a wall. Essentially, if you were to want to see what's beyond a wall, it's preferable to look through a window rather than the bricks. That is because light waves are able to travel through glass. Similarly, with ultrasound, one needs to find a window into the body where ultrasound or sound waves can travel. This is essentially any solid organ or fluid-filled organ that comes close to the surface of the body, for example, the bladder, the liver, the spleen, or kidney. Trying to look through ribs, which are highly reflective, or air, is similar to trying to look through a wall. In some cases, there may not be an obvious window, such as when examining the aorta. In that case, one has to create a window by gentle pressure, which will disperse the air. As an example, if one were to imagine this ultrasound probe trying to visualize the right kidney, do you think that this is a good acoustic window? At first glance, it may appear so. The liver is transmitting sound waves. However, if one notes the waves are traveling or would wish to travel through a rib, which is not possible. Therefore, the right kidney would not be visible. Instead, a shadow would be seen. However, moving between the ribs in the intercostal space would allow visualization of the right kidney. Similarly, to view the aorta in this picture, this would not be possible with the current approach, as the air in the stomach would obscure the view. So which probe should be used? Well, in general, there are two types, low frequency and high frequency. With high frequency, one gets high levels of detail but poor penetration, as more energy is attenuated with each wave. With low frequency, penetration is better, so deeper structures can be visualized. However, one loses the fine detail. Types of probe include a linear array or high frequency probe, a curved array, low frequency probe. These are the two most commonly used probes. Other probes include intracavitary probes, which tend to be higher frequency, and phased array probes which are low frequency, but again, both these have low size of footprints, small footprints, which allow visualization through small spaces such as the intercostal space. Having chosen a probe, a frequency, and being aware of the physics should lead to good ultrasound images, especially if the depth, gain, which is the volume, and an acoustic window are chosen carefully. However, sometimes there will be artifacts, that is, essentially things that are not in fact there, but appear on the screen. These need to be recognized. These include shadowing, enhancement, edge artifact, reverberation, and mirror artifact. A shadowing artifact is very simple. When sound waves are reflected, anything beyond that point in the far field or deep on the screen will in fact be a shadow, as demonstrated here with the gallstone. Enhancement is the opposite effect. As sound waves are not attenuated or reflected by fluid-filled structures, such as cysts or the bladder, more energy is transmitted beyond it, therefore there is more reflection far to the fluid-filled object. This leads to a brighter picture. This is called acoustic enhancement. Again, the gain or volume can be reduced to minimize the glare from such a bright reflection. Reverberation is when sound waves reflect between the probe and a parallel surface. Again, this can be seen often with the pleura. The multiple lines are in fact not real, but are an artifact. Mirroring is an artifact where there appears to be a substance in an area where it should not exist or does not exist. For example, with the mirroring of the liver at the diaphragm, it appears that there is liver beyond the diaphragm, that is above the diaphragm, where the lung should be present. You can see that this texture is very similar to that of the liver. And this occurs simply because of the 45-degree angle of the diaphragm, with sound waves being reflected off it, giving the appearance of a mirror image. Now, briefly moving on to instrumentation. It's very important to get to know your ultrasound machine, whichever type that may be. Simply, the simplest of things can catch out the practitioner. Knowing where the on-off button is can be helpful. Knowing how to enter patient details is essential, as images should be recorded. Again, know how to set up your machine. This will improve image quality. Simple buttons such as the freeze button, annotation for labeling images, and knowing how to save or print an image are essential components of scanning. To obtain a high quality image, one needs quality equipment. One needs to ensure contact with the skin with adequate amounts of gel. Setting the contrast or brightness is helpful. Setting the gain is essential, so that the gain or volume, how well the machine listens for ultrasound waves, should be set that in such a way that fluid is black, surfaces are white, and organs are grey. Power should be minimized to avoid the heating of tissues, especially those that are vulnerable, such as the retina or fetal tissue. Tissue harmonic imaging can greatly change the image obtained. This is the ability of the machine to listen for harmonics or multiples of the frequency. Depth or zoom, this is again important. Too much depth means that features that are close to the probe can be too small to see detail, and yet too little depth can of course mean that we miss deeper pathology. So again, it's important to start deep but remove the depth as you scan, so that the point of interest fills the screen. Resolution is generally a preset. The acoustic window we've already mentioned, that is looking for a way to transmit sound into the body. Body habitus can prove challenging, so moving the patient, asking them to change their position or take a deep breath can help generate an image. And again, the presence of bowel gas or free air can interfere with image generation. Finally, when you do start to scan, even for educational purposes, it's important that you record and audit your performance and move towards a system of credentialing and accreditation. Remember to look after the machine, clean the probe, and maintain the machine for others to use. I hope that this introduction provides some background and some key information that will allow you to understand point-of-care ultrasound and to begin to incorporate this fantastic tool into your clinical care and your clinical assessment of your patients throughout your career. Again, this is the introductory talk, and much more of this will be explained at the bedside during the practical stations and also with the simulation that you will receive. Thank you for your time.